أنا مش سامع حاجة.
Assalamu alaikum wa rahmatullah. How are you, doctor? How are you, prof? Could we start now the
Yeah,
webinar?
sure.
Okay,
Yeah.
we'll go. Now we are live in the YouTube, and inshallah, within a minute, inshallah, we'll start. I will give you a sign, inshallah, when we start the webinar.
Sure, no problem.
Thank you. I appreciate it.
Can we mute the background voice?
Are you able to see my screen?
Yep.
Yeah. Yeah.
Okay. So it's 12 o'clock Saturday.
Doctor, we open the webinar for the participant. Please wait for 2 minutes and start the webinar with thanks. Thank you all.
Thank you. Thank you.
Perfect.
So it's a holiday for you, and you guys are joining in to study. That's remarkable. I hope I can deliver something that you guys don't know.
You will, Prof.
So far,
You're a mentor for us, you know. You're a mentor for mostly half of the world now.
Yeah. So far we have almost 40 attendants.
Oh, that's great.
Yeah.
بسم الله دكتور فارس, could you start the webinar inshallah?
Yes. Bismillah ar-Rahman ar-Rahim. Assalamu alaikum wa rahmatullahi wa barakatuh. Welcome everybody. I would like to welcome everybody to this special webinar. We will be talking about an introduction about lymphedema surgery. I would like to welcome Professor J.P. Hong, our mentor. He's a former Godina fellow. He's a professor in Asan Medical Center and a professor in Ulsan University. He has a huge contribution to the field of plastic and reconstructive surgery. He's a scientist, surgeon, and entrepreneur. His major interest is microsurgery, super microsurgery, lower limb reconstruction, diabetic foot reconstruction, and lymphedema surgery. And he has a special interest in advanced imaging in microsurgery. He's my mentor and he's my good friend. Welcome, Professor.
Thank you very much. It's an honor and a pleasure to be with my good friends, catching back again, and to present some of our work that is being done at Asan Medical Center in regards to lymphedema surgery. So let me just jump right ahead. So when we talk about lymphedema, I think first of all, we have to understand what the lymphatic system is, and I know most of you do. So basically, the artery supplies all the fluid, the nutrition, and then sends out extracellular fluid, and these are collected back to the venous capillary, and 80% is drained by the vein. However, 20% is drained by the lymphatic system, and the lymphatic systems are mostly located on the lower part of the dermis, or in majority, large collecting lymphatics are located in the subcutaneous fat. This is very important anatomy to remember, as this is one of the essential core knowledges that you will have to know in order to provide surgery for lymphedema patients. And if you look at the anatomy itself, the deeper you go into the subcutaneous fat, especially below the superficial fascia, the lymphatic vessels gets larger. And these collecting lymphatics, as they go in deeper to the fat, they become larger, as you can see here in this dissection. And if we take a more closer look at the lymphatic vessel itself, it is propelled, it pushes itself by the surrounding musculature like the artery. So it has a internal mechanism of pushing and peristaltic movement, pushing the fluid toward the heart. And also it has a valve like the vein. So it's like artery plus, it's something in between an artery and a vein. And so these valves prevent the fluids, the lymphatic fluids, to regurge back. So these are also helping the fluid to move up toward the heart. And in addition to these internal mechanism, the extrinsic compression of the muscle itself also pushes the lymphatics toward the heart. So there is definitely an intrinsic system and an extrinsic system. So if we're able to assist the muscle pushing the lymphatics toward the heart, then we're able to help the fluid drain, the lymphatic fluid drain toward the heart. And this is why compression is very important, using this external mechanism by providing a compression stocking or compression bandage. It allows the muscles to push in more toward the lymphatics and squeeze it. And this is why the main frame of the rehab when patients have lymphedema is compression and exercise. So these lymphatics travel ultimately through our body and passes through many lymph nodes. And there are around 500 lymph nodes in our body. And all these lymph nodes are capable of providing lymph node flap later on, which we'll talk about, and also has to be removed in adjacent to cancer. So for example, breast, you're removing the axilla. For lower extremity cancer, you're removing the groin. For the uterine, for the for the gynecology, and for the prostate cancer, you're moving the intrapelvic or the intrapelvic lymph nodes. So remember that, you know, these lymph nodes are being removed and thus causing a blockage. But ultimately, the normal pathway goes all the way to the subclavian veins, left and right. The left is drains both legs and the left part of the arm and half of the face, and the right drains half of the face, the right arm, and half of the trunk. So in case of lower extremity, the left subclavian vein is a more key component. So the main question to ask when you see a patient with lymphedema is, where is the obstruction? So let's take a look at this congenital iatrogenic case. This is a 4-year-old patient, had a he had a congenital kidney agenesis, so no kidney. So they put a hemodialysis from birth, and while making that hemodialysis vessel, they ultimately ruptured the subclavian vein, and the entrance of the lymphatics to drain to the subclavian was blocked. So what did it do? It caused leakage, and then ultimately caused a chylothorax, as you can see here, haziness of the lung. So idea here is to bypass that obstruction. Can we make a lymphovenous drainage distal to the obstruction and provide an alternative detour? And that's what we did in this patient here. It was the left subclavian. So we worked on both extremity, provided a lymphovenous anastomosis on the leg, in the groin. And this is what happened. Look what we were able to do. So the pigtail was removed from the chylothorax, and the chest was cleared, and the patient was able to go on with business without getting a dyspnea. So understanding these principles really is the core of providing a solution to the problems that what we once couldn't provide. So basically lymphedema, knowing where the obstruction point is, knowing where the lymphatic structures are, knowing where the fluid is being accumulated, especially in the subcutaneous fat. And once the subcutaneous fat is no longer able to accommodate the fluid, it starts draining outside. So it is very important to understand the anatomy and the physiology. So here are cases of primary lymphedema and secondary lymphedema. The secondary lymphedema is the ones that we know it has a definitive cause. Primary lymphedemas are the ones that we don't know if there is a definitive cause. And these could be congenital, or these could come after a few years onto the life. So in case of primary lymphedema, the anatomy, the pathology is totally different. So in congenital, we think that there's lymphatic agenesis and there's lymphatic dysfunction in a combined form, which we'll be talking about later on. So primary, the fortunate thing is primary lymphedema, there's very little 95% of the patients that we see are secondary lymphedema patients. So a secondary lymphedema, the definitive causes mostly are from malignancy by removing lymph nodes, surgery, trauma, and even cases of DVT. Now, if you think about it, common sense, if you have a fluid accumulation in a towel, what you do is you basically squeeze the towel. And the same thing applies to lymphedema. The fluid accumulates in the fat and there's no drainage of the vessels. So what you're doing is you're squeezing like the towel and trying to push the fluid up physically toward the heart. The good news is that in acute lymphedema, 85 to 90% of early acute lymphedema responds very well to these kind of compression therapy or decongestive therapy. And this is why you have to work very closely with your lymphedema specialist or your rehab specialist. And this is the reason exactly why you need a multidisciplinary approach. Nevertheless, the fluid is accumulated in the fat and we're trying to get rid of that as much as possible. If it continues to accumulate, what happens? It starts draining outside and the chronic fluid ultimately turns into fibrosis of the fat and it really becomes difficult to manage. And as long as the fluid accumulates, what we see is an increased incidence of cellulitis. 30% of lymphedema patients will have cellulitis. If it proceeds, multiple repeated scarring ultimately develop into cancer, lymphangiosarcoma, and of course, in some patients leads to amputation. So knowing this anatomy and physiology is why multidisciplinary approach is so important. And what we also report is that there are patients that actually have high risk because not all patients that undergo axillary removal or removal of the lymph nodes in the intrapelvic area develops lymphedema. And what we have identified is that patients that undergo radiation therapy, patients that remove more than 5 lymph nodes, and patients that occurs at late onset is at risk for prolonged chronic lymphedema. And these are the patients that are targeted for surgical approach. Now, what is the alternative? The alternative is that these patients have to wear compression garment the rest of their life if there is no physiological reconstitution of the lymphatic drainage. And not only that, the suicide rate is high, depression rate is high, and there's a huge psychological factor as well. So as surgeons, how can we improve not only the quality of life, but also the quantity of life as well? And this is where the role of reconstructive surgery comes in. Lymphedema is not something new. It's been around more than 4,000 years. It's been documented in the Egyptian pharaoh times. However, even through relatively modern age of medicine, most of the operation were focused on removing the storage. So that is removing the fat. So how do we do that? Basically remove where the fluid is accumulated. And if you remove the fat, there is no place for the fluid to accumulate. So here's a patient that underwent debulking surgery in the past. Patient came back to us and we are able to see multiple recurrence. So what do we do again? We remove the reservoir, remove it, debulk it, and then the patient is able to improve somewhat. But the problem is this patient still needs to go prolonged lifelong surgery. An extreme form of debulking is the Charles procedure, a paper that I wrote with the Changdun group. It is what you're basically doing is you're basically removing all the fat above the deep fascia and then grafting it back, and this is the final result. This patient will never have lymphedema on the leg again where we did the debulking. However, what is the goal of surgery? If this patient wants to go out on the beach, swim, wear short pants, wear short skirts, this patient will never be able to. Even though we fixed the problem, we're not able to help with the quality of life. So how can we do better? And this is where a lot of liposuction approach has been approved, focused on. There's a huge group in Sweden, my good friend, and he does a lot of liposuction and it has a relatively good result. However, there's a very high chance that you'll have to continue to wear compression garment. But this is really useful in primary lymphedema patients where there's no lymphatic system. So we are not able to do physiologic surgery. So basically we go right ahead after evaluating the lymphatic system. If there's no lymphatics, we go right ahead with liposuction. And of course, the patient will undergo liposuction multiple times, but nevertheless, the patient is able to have a relative good quality of life, even in this 7-year follow-up. Quick method of draining in acute cellulitis stage. We also do horizontal excision and do MPWT. This is also a quick way to remove fluid, which has been working very well for us in acute cellulitis setting. Nevertheless, it is not a permanent way, but it really is able to put out the fire in patients with acute cellulitis. So all these patients, with the exception of Charles' procedure, needs to have a prolonged, lifelong compression garment therapy. So although we're able to improve somewhat, it is far being an ideal way to improve the quality of life. And this is where physiological lymphedema surgery comes in. Remember, all lymphatic fluids ultimately drain to the subclavian vein. And if we're able to help lymphatic fluid drain to the vein, it will improve the load and basically bypass the obstruction site. So this method is the first lymphovenous bypass, distal to the obstruction. And another way that we like to do is in the lower extremity, lymph node to vein anastomosis. And of course, in case we're not able to do LVA because the lymphatics are so small, but still there, and then these patients are candidates for lymph node flap transfers. And all these three methods are basically physiologic methods. And this kind of idea is not new. From the 70s, O'Brien group from Australia has tried, but had limited success. And why did he have limited success? It's because they didn't have the ability to find good functioning lymphatics. So they find sclerotic lymphatics in progressed disease. So they hook the vein up, but there's nothing because the lymphatics is already degenerated and it's not functional. So the key in order to have a good physiologic surgery is the power to identify good functioning lymphatic vessels. And of course, we have multiple preoperative studies that we do, lymph scintigraphy, MR lymphangio, using the ultrasound, ICG, and in some cases, gamma probing. So let's quickly take a look because this is very important. And this is the basic scan most of the lymphedema patient has. So what is this telling you? It is telling you the left side, the lymphatic flow is nice, but the right side, there is no flow. Does this mean that this patient, the lymphatics is functioning or not? We don't know because the lymph scintigraphy is an image only up to 2 hours. We don't know the lymphatic flow might happen after 4 hours, 8 hours, but nevertheless, this imaging gives you a rough idea if the lymphatic function is decreased or not. It doesn't give you exactly whether or not there's clearly a function in lymphatics or not. This is an ICG made popularized by Dr. Kushima, Japan, one of my mentors. And you could see that in patients with early stage, you can see a clear linear pattern. And those are the targets to do lymphovenous bypass. But what about these stage 2 and stage 3 patients? You see that there's no clear lymphatics. But does this mean that there's no lymphatic vessels? No, because the ICG is only able to penetrate maximum 15 millimeters. And when you see obese patients or patients with aggressive lymphedema, they all have subcutaneous more than 1.5 centimeters. So this doesn't give you an idea in late stage, nor a clear image of what's going on underneath the lymphatics. So let's quickly take a look at this imaging here. What we use is MR. This is MR lymphangio, and you could actually see clear lymphatics going in more proximal to the heart. But the problem with MR lymphangio is that it's very difficult to map out where exactly in the skin. So ultimately, we use the ultrasound to identify functional lymphatics with the vein nearby, and this has been our major tool. And you can see that you're able to identify lymphatics with high frequency ultrasound. So these are 18 or more megahertz of ultrasound, and then adjacent lymphatic vessel as well. And in this video, you could clearly see that the superiority of the ultrasound compared to the MR or the ICG. So here's a patient in early onset. In early lymphedema patients, you're able to clearly see lymphatic vessel, and then we use the ultrasound to map out the nearby vein. So we know exactly where the lymphatic and the vein is. So LVA is relatively made easy. Now, the problem is it becomes tricky when there is more advanced lymphedema patients. So here is a stage 3 lymphedema patients, And you can see that we did the ICG mapping and there's no lymphatic vessels. And we then bring in the ultrasound and we actually start mapping, and the ultrasound also does not show any functioning lymphatic vessels. So in our experience, for the advanced lymphedema patients, actually not to have any functioning lymphatic vessel is only 6 to 8%. So that means even if you don't see ICG or MRI, in 92% of the patients, you will see lymphatic vessels with the ultrasound. So here, again, you could only see vein in this patient. So let's take a look at another stage 3 patient here. Definitely stardust pattern. There's no linear pattern of the lymphatics. However, we bring in the lymphatics, and that blue-green arrow is the lymphatic vessel under the high-frequency ultrasound. And you can see it here with a different image. And we're also able to see a nearby vein. So the main tool to find functioning lymphatics is the ultrasound, as we published many, many times. So here's a patient again with a stage 3 severe lymphedema. And you can see that MR gives you some image, an idea that there's multiple functioning lymphatics. Again, mapping it with the ultrasound, knowing exactly where the nearby vein is, and we're able to provide this kind of surgery and a relatively good result. In some cases here, MRI and ICG, there's no imaging, but using the ultrasound, we're able to find the lymphatic vessel and ultimately provide a bypass. So the key here is, again, identifying not only functioning, but large lymphatic vessels to make your supramicrosurgery easier, and then finding a nearby vein, and that is the key. So the main approach for us has been the ultrasound for a very long time to map out the lymphatics. So if you want to start lymphedema, especially supramicrosurgery, such as LVA or lymph node to vein, or even lymph node flaps, these ultrasound are essential for supramicrosurgery. Now, the term supramicrosurgery was made by Dr. Kushima, and this is an idea where you anastomose vessels less than 0.8. Why is this idea different? Because in the past, we were told that 0.8 or less, has a high rate of failure. And this is why with improved instrumentation, improved sutures, 12-0, 13-0, and improved magnification and also imaging, it allows us to do these kind of small vessel manipulation, and hence the idea of a different category of microsurgery, which is supramicrosurgery. And again, we're able to see not only functioning lymphatics, but it increases the higher chance of success. So let's quickly take a look at the first set of the physiologic surgery, which is the lymphovenous anastomosis. So here's a video how typically it's done. This is the classical Kushima way, where we take the subdermal lymphatic vessel. So here, the skin is being opened under the microscope, and right under the dermis, we're able to see a lymphatic vessel. In this case, we use fluorescein dye. So we find the lymphatics, and that's a 6-0 nylon next to that lymphatic vessel. And then we suture the superficial vein, and ultimately the lymphatics drains to the low pressure vein, as you can see here. And this is only about 0.3 millimeter. So it's very painful, but it is doable. And you can see in a bit, the high pressure lymphatics will drain to the vein. Now, we'd like to take both ends of the lymphatics because they're both high pressure. And if we can, try to anastomose both ends. And you can see how the superficial vein already turned yellow, proving that there's a clear drainage of the superficial of the lymphatics to the vein. So again, it works by using the pressure gradient of the high lymphatic pressure to the low lymphatic vein, low pressure vein. In the leg, when the patient is lying down, the normal venous capillary pressure is around 20 millimeter mercury. In the groin, it's 8. In the abdominal cavity, it's 3. In the arm, near the armpit is around 2. And you can see that how the pressure, even between the lower limb and the upper limb, is different. And this is why the LVA works much better in the upper arm, because the pressure gradient is much higher. Now, when the patient is standing in the leg, it's around 90 to 110. But look how much it is reduced by the muscle squeezing movement. As the muscle pushes the vein pressure decreases to 20 millimeter mercury. And this is why compression and physical therapy is very important. and asking the patient to exercise because it is able to maximize the pressure gradient. Let's quickly take a look at the normal lymphatic pressure, which is around 12 to 70 megahertz. So usually, even if you do a bypass, there's no pressure gradient between the vein and the lymphatics, and this is why it doesn't work. However, when there is a block of the lymphatic vessel, the pressure increases up to 200. And this is why LVA is able to work. High pressure lymphatics flowing to the low pressure vein. And this is the idea between using the LVA and maximizing the pressure gradient with compression and exercise. So the key in doing the LVA is, again, selecting the functional lymphatic vessel using the proper imaging. And you can see here this wonderful work done by our good friend, Dr. Miharu from Japan. You could see that as the stage advances, the degeneration of the lymphatic vessel is clearly seen. But yes, was there any question? But if there is, but the thing is, in stage 3, the majority of the lymphatic vessel may be degenerated or sclerosed. But the trick here is to find the ones that are still functioning. And I told you around 92 to 95% of the time, you will be able to find function in lymphatics, even in these advanced cases. And not only that, find large lymphatic vessels using the proper imaging. So the ideal lymphatic vessel is the one that is functioning and that is relatively large, which is located in the lower bottom of the fat. And the main components of successful LVA, of course, is finding a good lymphatic vessel and finding a good vein. And again, the dissection is focused on finding a functional lymphatic vessels in the deeper part of the fat, as you can see here, clearly a larger diameter. Now, there are multiple ways to do the anastomosis, end to end, end of the lymphatics to end of the vein, or the side of the lymphatics to the end of the vein, or the end of the lymphatics to the side of the vein, or side to side. And for a long time, we didn't really know which is superior. So let's quickly take a look at this video here. And the way we do lymphatic surgery is basically use the idea. So here, again, fluorescein, one is a superficial vein, and one is a lymphatic vessel. It's relatively large. And under the microscope, it's relatively clear fluid. So it's very difficult to differentiate. But when you use these kind of color markings, it really gives you a better imaging of the margin of the lymphatic vessels, allowing us to have a better chance of suturing. So identifying with lymphatic uptake in fluorescein in this case, and you could use lymphosorm. It's also a blue dye, but in our case, we like to use yellow dye because it clearly distinguishes between the blue marker that we use. And then ultimately, you can see a clear margin of the lymphatics, and then we're able to anastomose the vein. We prefer doing side of the lymphatics to the end of the vein. This could be a little bit technically tricky, but we do believe this is superior. So here's a quick video of the side of the lymphatics to the end of the vein, and you can see that it is collecting lymphatics from the both distal and the proximal. So it's collecting from both regions and clearly draining into the vein. As you can see here, we anastomose 2, and it is draining into the vein. And we recently reported that in early stage 1 or stage 2 early, doing end-to-end and doing side-to-end doesn't have any difference. But however, in more advanced lymphedema, such as stage 2 late or stage 3, there is a statistically significant difference in outcome. And why is that? Because as the lymphatics dilates, it starts to lose the intravalvular function. So you're starting to see backflow in more advanced lymphedema patients. And this is why the side-to-end anastomosis to the lymphatics is clearly superior in more advanced lymphedema patients. So here in stage 1 and 2, you could see a significant improvement, and these patients in 30% of the time will wean off completely from garment. So they don't need to use garment for the rest of their life. This was a case from the Middle East, congenital scrotal lymphedema. Nevertheless, we found it, and this is the follow-up after several months after doing LVA, and you can see that there's a significant improvement early as day 4 and in the follow-up months of this patient as well. So for advanced stage lymphedemas, here, stage 2 or 3, again, same principle. We're able to find functional lymphatics and basically hook it up to what is still functioning. And this is the result. 5 years, stage 3, no compression garment. So this patient was really happy, and we approached multiple levels. Same patient I just saw you before, 1 week with compression. Look how much deflation that she had. So we reported this in the PRS journal, and this really switched the paradigm, because in the past they said stage 2 late, stage 3, functional lymphatic vessel, functional surgery doesn't work. But we proved it wrong, and we're able to show that as long as you find functional lymphatics, even in stage 2 late and stage 3, these kind of lymphovenous anastomosis clearly benefits the patient as well. So again, utilizing the pressure gradient allows us to reduce in volume, and also a significant reduction in cellulitis. As we published multiple articles, we're able to have 77% symptom improvement, cellulitis from 2.6 to 0.12 per year. So there was a clinically significant reduction. So let's look at a second way we do physiologic surgery for the lower extremity is lymph node to vein anastomosis. So what is this idea? So if you look at this lower extremity here, the patients who undergo intrapelvic surgery, prostate cancer, gynecological cancer, most of them, they remove the lymph nodes from the iliac vessels. They don't remove from the inguinal groin. So the obstruction point is in the pelvis. It's not in the groin. So what do? We presume that the lymphatic flow is good all the way up to the groin. And then ultimately, we use the groin node to hook up to the vein. And this idea, again, is not new. It's from the 60s. Polish group used it. But again, the result was not significant. Why? Because they didn't have the ability to find functioning lymph nodes. So if you look at this lymph scintigraphy here, just because you're seeing no node uptake, it doesn't mean there's no nodes. If you look at the MRI, there's clearly large nodes, as you can see here. And then we're able to find these and hook up the vein. And we reported this in the J-Press a couple of years ago, and we're able to see very good results. And again, this is not super microsurgery. It uses large vein hooking up to the vein. And this is how the illustration is, and basically allows it to drain. So here, the way we like to do lymph node to vein anastomosis, again, inject the ICG in the toe, wait for 15 minutes, find the superficial vein, identify the direction of the drainage, then you cut the lymphatics, and then you try to find the lymph nodes. So how do we try to find functioning lymph nodes? We try to see the one that has uptaken ICG. So clearly it has an uptaken ICG here. So we puncture and make sure that we enter the cortex of the lymph node. And once we identify the fluid coming out, the lymphatic fluid coming out, then we go ahead and anastomose the superficial vein. And then we confirm that there is drainage. So you could see here with the ICG, there's clearly fluid coming out. And then we're able to know that this is a functioning node. And you can see clear increase in the ICG uptake in fluid. And then basically that's when we do the side of the lymph node to the end of the vein. And we're able to have significant results, especially in the genitalia and the upper thigh, as seen in this patient here. Now, the idea of doing lymph node flap is replacing what is missing. So the patients, we like to use this mostly for upper extremity when the lymphatics are degenerated much, or when we need to make sure that they increase the chance of a good result. Then we like to do LVA in conjunction with the lymph node flap to basically provide what is missing. So here in the upper arm, LVA and lymph node flap, and we're able to see improvement. So how does this work? It works by repairing the continuity of the fat. Remember, it's the fat where the lymphatics are. So by putting the fat with the lymph node, it repairs the continuity, and by removing the scar. And this is why scar removal is so important. And then ultimately the lymphangiogenesis occurs in the fat, and ultimately drains to the node. And so that's how this lymph node to the lymph node flap actually works. So going back to our approach, our strategy here for the upper extremity is, again, stage 1, stage 2, stage 3. We all center the rehab, make sure that these patients are not responsive for compression therapy. And if they're not responsive, then they're candidates for surgical approach. In this case, we customize to each patient, LVA only, lymph node flap only, mixed, or even with liposuction, or if that doesn't work, liposuction alone. The lower extremity is similar principle, customize it according to what the patient needs, sometimes LVA and LNVA alone, or LVA alone combined, or also LNVA and LVA combined with liposuction. Of course, there are a lot of new science being tested. We're also doing a lot of preventive lymphatic surgery as well, which is a topic that we'll go into next time for the sake of time. And then, of course, we're using flaps, using their lymphatic pathway and ultimately utilizing that to improve the lymphatic status. Now, for the preventive lymphedema, this is a very controversial subject because in our center, we're doing almost 8,000 breast cancers a year. 8,000. Can you imagine doing 8,000 LVAs, preventive LVAs in the axilla? There is no way we can do everything. So we focus on high-risk patient. We talked about what is the high risk? Scheduled for RT, most of the lymph node dissected. These are the patients that we focus in preventive lymphedema surgery. Here is a patient where we reorient the pathway of the lymphatics in cases where the medial thigh has trauma. So we orient the pathway, making sure there's a fat continuity and ultimately allow the patient to have improved lymphedema. This is not with LVA, but just by providing a pathway, reconstructing the pathway of the flap of the fat, the lymphatic pathway allows a better lymphatic drainage. So today, my given time was only 30 minutes. We had a basic introduction and idea of the anatomy and physiology of why lymphedema occurs and what we utilize in that physiology to provide a physiological reconstructive lymphedema surgery. We also talked about the importance of compression and exercise and collaboration, teamwork, multidisciplinary approach to make the effect the highest. And we also basically talked about what is our strategic algorithm. I think the most important thing is that, there's a lot of frustrations involved. There's a lot of techniques that are involved, new ideas that are involved. But I think, as Dr. Kushima taught me, that we have to believe that it works and one day you'll be able to do lymphedema surgery. This is exciting because it's an ongoing science. A lot of it is preliminary finding. The surgery itself I've been only doing it for the last 17 years. These are most preliminary findings. And of course, there's a lot of perseverance, patience involved in building these technical skills. But I am very proud to say that we're able to provide hope in patients which had barely no solution, no permanent physiological solution before, in 1 out of 100,000 primary lymphedema patients, and in 20% of the patients that develop lymphedema after lymph node removal. So we are surgeons that are giving hope. So with that, thank you very much, and I'll be more than happy to entertain any questions that you may have. Thank you.
Thank you, Professor. Excellent presentation as usual. Any question from the audience?
So thanks a lot, Professor JP. For the audience, can you write your question in the Q&A section as well, so we can take it from Professor JP directly?
I have a question, Professor. What do you think about conventional liposuction versus laser liposuction? I saw a lot of Dr. Hakan from Sweden patients, and the results were excellent. And he's using only conventional liposuction.
Yeah, I mean, Hakan is a good friend. He's actually done more than 10,000 lymphedema patients just by doing liposuction, and his results are remarkable. Hopefully, we could have him in this panel in the future one day. For us, I don't believe there's a huge difference in using conventional and also using ultrasound assisted liposuction like the Vaser. We prefer to use ultrasound assisted because I believe it's easier. And I also believe that it breaks down the scar much easily. So for us, our main mode of doing is using ultrasound. But again, there's no study comparing directly between the conventional liposuction and the ultrasound. So this might be something of future research. But I do believe both of the modes actually gets the work done.
Okay.
Thanks a lot, Professor.
Actually, I have a lot of questions. One last question, if you mind, Dr. Firas.
Right.
Professor, in our population, we have a lot of patients with obesity, with a BMI more than 40. And we have also lipedema patients. They are all coming with lymphedema. My question is, for the patient with high BMI who require surgery, like sleeve or bypass, would we defer the intervention of lymphedema later on, LVAs and vascularized lymph transfer, or it doesn't matter?
Yeah, this is a very good question, and of course you, Faris, when you were here, you saw, and also Faris when he's here right now. So we talk a lot about this, and what we found is that, and again, there's a lot of documented proof that obesity is one of the high risk factors in developing lymphedema and also developing into a chronic lymphedema. And so this is a very important risk factor. And we've actually seen evidence after bypass, sleeve or gastric bypass or bariatric surgery. A lot of these patients actually improve their lymphatic function. So for us, if we see a patient with a high BMI, we tell them, if you really are serious in improving the lymphedema of the limb, get bariatric surgery first. And then we'll be able to talk, because it's painful because of the obesity. Even though you're able to do a successful surgery, the patient will have less remarkable result compared to the patients who underwent bariatric surgery and has functional lymphedema surgery. So our protocol is always bypass bariatric surgery first, and then we review again.
Perfect, Professor. Professor, can I ask you something? During my time here, I saw many patients from Middle East, and I know that we are part of the screening protocol that you're implementing here is doing a genetic testing. So can you enlighten us about the summary of the commonest condition that you deal with, which is basically our population? In terms of genetic mutation and genetic syndromes that it's common in our region.
Yeah, I am privileged to work with the governments in the Middle East, and they refer the patients to me. So it's a privilege to work for your patients. And what we found is that a lot of the primary lymphedema, especially the congenital lymphedema, have a syndrome, a Noonan syndrome, which is syndromic with lymphedema, heart condition, and also develop into chylothorax. And if they come early enough, we're still able to find functional lymphatics and improve their lymphatic drainage. So their nutrition becomes better, their chylothorax or their chest symptom improves significantly. But if they miss the window of the surgery in their early period of life, then we're not able to help them because the lymphatic vessels will be degenerated. So if you see this kind of congenital case, I think most of the times you will be able to help them through this physiological approach. Regarding the genetic workups, we're currently collecting the genetic markers for these patients, and I think we'll have more data to share with you in the coming years. Thank you for your question, Faras.
Thanks a lot. Really appreciate it.
And you're a great help, man. You make these patients you and Faris, when you were here, you guide them, and you give them comfort. And I think this is an example of a wonderful collaboration between us and you guys from the region.
Thanks a lot. It's really our pleasure. We didn't do anything, really appreciate it. Faris, you have any question?
Yeah, we have one question from Dr. Mohammed Al Fawzan. He's our colleague. Also, he has his fellowship in Korea, I think in St. Mary's. He's asking how to determine the number of LVA needed for a given patient. And his second question is, can LVA surgery be done under local anesthesia?
Yeah, so answering your second question first, definitely it could be done under local anesthesia. But again, our approach a lot of the times entails not only LVA, but mixed with lymph node flaps or mixed with LNVA, lymph node to vein anastomosis. In this case, the surgery becomes complex, a little bit longer. So our preference is to do under general anesthesia. However, we also do a secondary or tertiary LVA, and these patients are actually done under local anesthesia when we need to do just 1 or 2 LVAs. Regarding your first question, how many LVA is enough? In the past, we used to do a lot. We thought more the merrier, but it actually turns out that as long as you do 1 good functioning lymphatics, that is enough. That makes a significant difference. Now, people may argue that there is 3 to 4 lymphangiosome territories, so lymphatic territories. But what we also see is that in advanced cases, there's a lot of backflow. So by doing just 1, we are able to see clinical difference. If we're able to find 2 functional in a different lymphangiosome, then we will do 2. But it's very rare, and okay, again, we're doing everything side to end. For us, it's very rare to do more than 2 lymphangiome territories. Now, if you're doing end-to-end, it's a whole different story. I think end-to-end, the more is probably better. But for us, end-to-end doesn't make sense because you're actually cutting a functioning lymphatics and you're preventing, you're actually cutting the functioning unless you're, anastomosing both ends. It doesn't really, I don't know, for us, it doesn't really make sense that you're destroying one lymphatic to do LVA. So for us, side to end is the mainstream to go, unless it's impossible to do side to end. In that case, we do end to end.
Perfect. One point, Professor. I'm glad to tell you that we reached almost 100 participants.
Wow, thank you.
Yeah, and I know that most of there is quite a good number of our participants are lymphedema therapists. So your kind of collaboration as a surgeon with the therapist, how did you reach to that harmony in management for us to establish similar protocol in Saudi?
Right. So the first thing is, at the end, it was difficult for us as well because we didn't exactly know, and we as surgeons we want to operate, but it turns out that you have to learn from each other. As I was saying, in stage 1, especially in upper arm lymphedema, stage 1, early onset, 80% will get better just by compression. So, there was a lot of, controversy on plastic surgeons doing stage 1 because it's easy. The lymphatics is easy. However, if you think from the patient's sake, she might be getting, a surgery that's not really needed if she's going to undergo compression therapy. So I think for us, the screening is mostly done by the rehab first, and unless it's stage 3. And then once the rehab physicians or the technicians say, oh, it's not working, then the patient is referred to us. I think in your region, it might be a little bit different scenario because I know that's very hot. It may be very difficult to do compression. So maybe the indications could be a little bit broader or a little bit earlier. But nevertheless, I do believe the gateway should be the rehab people. Second is that even after the physiological surgery, massaging, compression is still a very important component to maximize the pressure gradient. So as plastic surgeons, we're not experts in bandaging. Although we're able to do it, there's a lot of science behind bandaging. And I think this is why creating the right team, always communicating with each other, at the end, developing a lymphedema specialized clinic or center is probably the way to go.
Sounds great. Thanks a lot. Really appreciate it. Dr. Yasser.
Sorry, I have emergency care by the morning, so I joined late. but I enjoyed the presentation so much. For me, I am not a microsurgeon, so I will ask something in this field because many cases I see, but they are mostly in late stage 1 or 2. They want to get rid of the bandaging or want the compression therapy, or some of them are not compliant. Some of them are not benefit from this. When I can advise patient to go for two things. One, if a patient with stage 1, shall I advise him to go for a specialized center for microsurgery to he will benefit from such lymphovenous anastomosis or lymph node transfer, or it's better for him in early stages to continue for conservative management? This is one thing. The other question, if I have a patient not compliant or not benefit from pressure therapy and he is in late 2, most of cases are in this stage, will I push him to go for this physiologic operations, or I will push him for something more conservative like liposuction, and it will be much easier for him? So I will treat him or I will transfer him. This is important for me because we are not here. I am not a microsurgeon and we don't have a center like this here.
Thank you, Dr. Yasser. This is two very important questions, I think. Again, going to your first question, if it's an early onset stage 1, I would definitely, transfer the patient to the rehab and say, hey, look, if you're compliant, you might not need surgery. 80%, will recover. So, go to the rehab until the rehab gives up and say, oh, you cannot do it. The second question is in regards to compliance. I make sure that the patient is compliant to compression prior to surgery. If the patient is not compliant, then I tell them I cannot operate. The outcome of the operation is going to be suboptimal. So in order to have the maximum output, you must be compliant to compression. So I send them to rehab, and then I make sure the rehab says she or he is compliant. And once I am comfortable knowing that the patient is compliant, then those are the patients that I will prioritize in the operation. I've seen many patients from the region and I know that they're not compliant, but somehow I tell them, hey, look, this is your last chance. I mean, if you're not going to do this, there's a chance that you're going to develop cellulitis and have a miserable life. So be compliant, dedicate a couple of years and see if you have a good outcome. So I think, yes, the patient is inherently not compliant, but I think definitely we can train them. And I think this is why we always share our progress. Every time they come, we say, oh, look, you decreased 2%, 1%. Your imaging improved. And I think we're able to motivate them and get them in the process and actually motivate themselves, motivate the family members, and ultimately make them compliant to compression. I mean, there is no trick. We cannot say, hey, look, if you don't wear compression, it's still going to work. In the past, they thought it might. It will to a certain degree, but it will recur really fast. So I think it is very important to have the patient compliant in our experience.
For this patient, he is compliant, but he did not benefit. Will I push him for lymphovenous anastomosis?
Yes,
or
yes.
It's much better
so.
than the debulking procedure or liposuction?
Well, again, like I said, in stage 3, around 6 to 8% will not have lymphatic vessels. So we need to do imaging studies to actually determine whether they will benefit from the physiologic surgery or not. If there is functioning lymphatics, he or she will benefit. But if it's that 6 to 8%, which all the lymphatic system are degenerated, we cannot find functioning lymphatics. These are the patients that are definitely indicative of debulking surgery only. A lot of the times in stage 3, we mix the two. We mix debulking with physiologic surgery. And the reason is that physiologic surgery will prevent further aggravation. So once we reduce the volume with the debulking procedure, there's a good chance that it will remain the same. So this is why we combine in stage 3.
Do liposuction alone can destroy the lymphatics, making further operation more difficult for you?
This is a very, very good question. And we thought this was the problem. And, doing liposuction will destroy the lymphatic system. some of the preliminary findings that we're investigating right now, and we're gathering the data, is when we see a patient with liposuction in the beginning, we do believe, yes, it is destroying the lymphatic system. But like all vessels, lymphatic vessels has the power to regenerate. And if the lymphatic burden is decreased by debulking, we believe that the lymphatic regeneration would be better. And we're slowly seeing evidence after liposuction, the lymphatic regeneration is still happening. So if we're doing, so what happened to us is after we do debulking, we come back a year later, we do imaging and we actually see functioning lymphatics, and then we do secondary LVA. So this is why all the approaches need to be customized according to the patient's development or progression. This is a very good question. Hopefully we'll be able to provide evidence, but our preliminary findings from imaging, especially using the MRI, is suggesting exactly that. Thank you for your question. Very great question.
Thank you, sir.
Thanks a lot. Thanks a lot, Dr. Yasser. Thanks a lot, Professor. One quick question. I think it's touching a point that we already discussed, but specifically after compression, compliance with compression, rehabilitation, everything, when a therapist can refer a patient to microsurgery, how long they should wait?
Yeah, so if you talk with your rehab specialist, usually they have some mode or method to measure the circumference, or do a bioimpedance test, or measure the volume with 3D imaging. So there's many ways to do this, and they will actually see whether or not there's a decrease in the overall outcome. And when they see that, most of the times they will stay with the rehab. If it's a steady or even accelerating in regards to increase in volume, then that is the point that they would refer. In our center, we also use what is called a 2-week challenge. So they do a very aggressive compression therapy for 2 weeks. And if it responds to that, then they know that there's a chance that the patient will benefit from compression. In 2 weeks, if there's minimal change, then they will refer the patient to us.
Sounds great. I think one last question is from Faris. He's saying that is there a need to do follow-up after anastomosis, either short or long-term, to assure the patency of the anastomosis?
Yeah, this is, again, a very good question. And if you look at literature, there are a few literature, not many, but few literature saying, oh, after 1 year or after 2 years, the patency rate is around 50% or even less than 50%. Now, if you think about it, it's not because, of the anastomosis or anything. It's because the pressure gradient, the high pressure lymphatics, as you drain and the vein pressure remains the same, it will, as it drains, it will eventually stable out almost the same pressure as vein. And when this happens, this is when the LVA will stop functioning. And this is why LVA sometimes recurs if the patient is not careful. And this is why we say, hey, look, if you're doing strenuous exercise, make sure the compression is on from time to time. And this is called partial weaning. So we believe that this is really dependent on how much the pressure gradient recovers into normality. And I think that is the cause for the maintenance of the LVA or not.
Sounds great. Sounds great. I would conclude this talk, Professor. I really appreciate your time, and I know there are many questions, and one question can lead to another question, especially that we are really striving to know more about this, as we are struggling with many patients here that are really in need for a touch or an intervention that can alter their lifestyle. So thanks a lot for your time, and I really appreciate your time. And
Thank you.
I think I will shift to introduce Professor Sabah Musharraf. Professor Sabah, she's a professor of plastic surgery. She's the previous head of department at King Abdulaziz University Hospital in Jeddah. Welcome, Professor Musharraf.
Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you very much for your inviting me to present my talk. it was excellent, Dr. Prof. GB. His talk was really excellent, but the problem in our country is completely, I think it's completely different. I'm sharing my lecture. We are presenting our experience at King Abdulaziz University Hospital in managing lymphedema cases. As he explained, what is a problem is a common condition with chronic progressive distressing debilitating disorder resulting from impaired lymphatic system function with various etiological causes and due to anatomical alteration of lymphatic system. Usually the presentation of the patient usually mainly after breast surgery, and for the lower is different. The breast surgery, post-breast surgery complication improved after centennial lymph node, and the causes of the etiology type and the causes of the diagnosis of lymphedema depend. We have primary, secondary, and primary miliary precoxal tarda, and we have the traumatic secondary trauma, surgery, infection, and venous post-venous thrombosis. Diagnosis lymphedema mainly by history, symptom, and sign, and physical examination. Physical examination using tab or volume displacement or skin evaluation, and imaging technique. Imaging technique, there is variable type of imaging technique, and we are using in our study after history and examination, we use lymphoscintigraphy, sometimes using MRI. The presentation of our cases is completely different. Primary, we have children and adults sometimes came with primary causes, and we have secondary. Usually when we start on 1985 in our hospital seeing these type of cases, our hospital is a university tertiary hospital. It was coming cases of post-trauma or lymphatic obstruction due to parasitic infection, especially from Africa. And the most of our patients, they came on very, very bad and complicated cases. This is the type of patient we are seeing in our hospital. They are severe bilateral lymphedema or unilateral with extensive with recurrent attack of cellulitis, like the son obesity and cellulitis, and this also with chronic cellulitis. This is the type of our patient we are seeing, and this is post-mastectomy. And even in the post-mastectomy cases, we are seeing the late cases. They don't refer the patient to us. This is type of lymphedema is lymphedema plus local lymphangitis swelling. In children, we see some cases like this. So how we diagnose, I said by history and examination, and how we find, how we confirm the diagnosis if there is a change between normal and abnormal side. And according to that, we stage that problem. If there's minimum 1 to 1.9 in the circumference, we take the circumference mid arm or mid leg, and we measure the different. If the different, if it is 1 to 1.9, it is minimal. If more than 2 to 9, 2 to 2.9, it's mild. If it is more than 3, between 3 and 3.9, is moderate, and severe cases more than 4 centimeter. The difference between normal and abnormal. In case of bilateral, usually it based on the measure pre and post therapy, and usually we confirm by lymphoscintigraphy. For evaluation of the improvement of our patient, the same we take the point of mid thigh, we usually use mid leg or mid forearm, and we see the difference before and after treatment, and if there is improvement of the skin texture, softness, and the lymphoscintigraphy. Usually, the treatment is challenging for the treating physician, as indicated by increasing number of modalities and procedures, frequently modification, combination of these procedures. It is important. Proper understanding of non-curability nature of the lymphedema and acceptance of reasonable control in progressive limb and improvement of stated cutaneous complication. This is we consider as improvement. And our aim to improve lymph flow through existing collateral drainage, eliminate protein stagnation, restore normal lymphatic circulation, as Professor GB is explaining, prevention of complication and progression of the disease, avoid extensive irreversible fibrotic and sclerotic tissue in the lymphedema. The key of the success in, I believe, prevention, early detection, and patient education, it improves the outcome maximally. This is the current available management procedures as it was described by Professor before. It was more than enough. And what Ari will describe, he described all this type. Our management mainly is conservative and liposuction I will discuss later. This is we start liposuction with Hakan Brosson. We start in the lower limb on 1987, and he start in the upper limb. This is other type of reconstructive surgery. It's reconstructive technique. And I'm presenting my experience management of these cases over the last 37 years by using combination therapy all patients receive conservative therapy in the form of skin care, external compression, limb elevation, and exercise, and reducing weight, of course, complete decongestive therapy, followed by, if the patient have not improved or he can fail in any stage, he will receive complete decongestive therapy in manual lymphatic drainage, compression therapy, and meticulous skin care, and remedial exercise. He should do all this. Then if the patient after this still need another stage or improvement, we shift to liposuction and go back again to conservative, and if he need, we follow with decongestive therapy. And later we progress. The regimen of our treatment in our hospital, we start 1985 as conservative, and most of the patients improved with especially stage 1 and 2 with conservative therapy if the patient compliance is good. On 1987, we start liposuction to improve the difficult cases and complicated cases. And on 2007, we introduced the complete decongestive therapy through our physiotherapy department. And on 2011, we introduced the low-level laser therapy. What is the action of the lympholiposuction? It is body contouring, need general anesthesia, pressure tourniquet, under pressure tourniquet, and antibiotic. We don't follow the Prof. Hakan technique. We do our own technique by doing, we do half of the limb, not the whole circumference. We do half the limb in one time, and then we follow the other half in after 6 to 8 weeks. Our technique, we do liposuction, all the half 50% of the limb, and we do tunneling under the normal skin. Between the normal and abnormal, we do tunneling. We do liposuction by liposuction needle. We do tunneling. These channels between normal and abnormal. We use the importance of liposuction. It is excellent in debulking, especially dorsum of the foot and the hand. What is the effect? It's reduction of the tissue forming lymph of the subcutaneous, which is the forming lymph, increasing lymphatic flow, downstage limb swelling, it contoured the limb, especially if you have abnormality of the contour, then the patient cannot wear the elastic stocking. Then we downstage this one and we make the contouring smooth, and then patient can continue the conservative therapy. This is the first patient we start. She was 25 years with chronic lymphedema, stage 2 to 3, and patient came. This is 1987, and after lympholiposuction, we do half them and then followed by the other. And this is after 2 years. This is after more than 10 years. The patient was still maintained on that therapy. At the beginning, before we start the patient, we do lymphoscintigraphy, and the isotope stagnant was in the foot, was not crossed to the proximal area. After 5 hours, still the same, no change. And this is after 24 hours. We can see there is the lymphatic after treatment. You can see the lymphatic improved and reached to a level of the abdomen. So this patient before and this is after. For the upper, we introduced this technique for upper because at the beginning we don't have upper limb lymphedema till late stage because the patient was not coming to us, and after the improvement of cancer treatment, the patient start coming with different stages. So we do the same for the patient. We start doing liposuction 50% of the limb. We do the channel between normal and abnormal under tourniquet, general anesthesia and tourniquet, and with antibiotic. And this is the patient preoperatively, and this is the patient after 2 years, maintain. And this is after 4 years. And this is the lymphoscintigraphy showing the difference before and after. There is improvement in the flow of the lymphatic fluid. So sorry for this. Indication for lympholiposuction. If there is major increase in the size due to failure of patient to follow the conservative treatment, if there is major deformity, uneven surface, a long-standing pronounced lymphedema, do not respond to conservative measure due to slow or absent lymphatic flow, then we take patient for lympholiposuction. It usually accelerates improvement of conservative treatment, but particularly in the patient with unsatisfaction with level of reduction of the limb size, then we take him for lympholiposuction. And if there is a large limb with heaviness, which cause fatigability, and then liposuction will reduce, like this case, and improve the outcome. Usually, lympholiposuction improve the quality of life. And this is the first publication. And then we do for upper, that one for lower, it was 2004, and this is for upper and lower. This is showing this research showing the frequency of post-mastectomy lymphedema, and usually it's high, around 40 at the beginning, and then improved after central lymph node. And this case, we have lymphedema post-mastectomy. She came. The lymphedema has 20 years duration, and when she came, you can see there is increased circumference of the hand, severe. And after we do her liposuction, you can see there is the difference before. There is in the arm and in the hand very high difference. And after we do liposuction, there is improvement. After 3 years, you can see after more than 3 years, you can see the improvement, and the patient continue on conservative therapy. And this is a patient again. You can see the same patient This patient have secondary lymphedema due to cases, parasitic infection from Africa. We do for him many stages, and he has improvement. This is after. And this primary lymphedema in 18 years patient, and we do for him lymphodepletion, and this is after. This patient, you can see, she is having lymphedema. She came on 1994, and we do for her liposuction, and she was follow up until 1999. The improvement was excellent on conservative therapy, and she came on 2005, and she came now 2021, and she has improvement, no more liposuction, only conservative therapy. And this child, she has lymphedema of the right limb plus lymphangioma tissue. When I do her, it was a difficult case. What I do for her, I do liposuction. It was fibrotic, and I do channeling all over the area between the abnormal and normal, channeling all over the area. And after 2 years, there is much improvement. And I follow her. I do another stage, and this is after 6 years. And we found, and this is during operation, we take biopsy to see what is it came lymphangiomatous structure.
Professor, may I interrupt you? I think the screen is frozen. Can you reshare your screen again? The screen is frozen on one of the previous slides. It's not following your presentation. Can you just reshare your screen again, please?
I see.
Yeah. Thank you.
I cannot find this. Share. No share. Which slide?
It was on the study of the before the picture of the child.
This one.
So I will stop sharing, and then you can share again. Okay.
Okay. And this slide, I think this one.
Okay. Thank you.
Okay. So this patient, she has long follow-up from 1994, 1998. She has liposuction here, and in 1994, and she follow the conservative method until 2021, and she has improvement. This child, she has the lymphedema and abnormal swelling of the thigh. She's 2 years child, and we did for her lympholiposuction. At the same time, I do for her channeling between the abnormal and normal all over the area. And after there was much improvement. Then this is after 6 years, and this is during operation. Nothing coming, yani there is only fibrosis. And what we do, we believe in creating a channel between abnormal and normal tissue. And you find this patient after 12 years, she is on conservative therapy and compression therapy, and there is no more swelling in that area, and there is improvement of lymphedema at the same time. So, what about laser therapy? It is low laser therapy, non-invasive cold laser, and it is on 1998 group from the of American Cancer Society. They start study the laser lipotherapy, low laser therapy on lymphedema. They found it improved the lymphedema cases by action on the lymphocyte and macrophage, and I follow this study, but I changed the technique. I use the laser on the whole limb and on the lymph node at the axilla or in the leg. in the groin area. And I found, they found, and I found the same, there is reduction in the whole arm volume, and there is softening of the decrease the extracellular fluid, and there is softening of the hard dermal tissue. And it is low laser of 635 nano, and it is non-invasive, no thermal effect. There is significant improvement of the volume and significant reduction of the dermal hardness, and as I said, it affects the macrophage function and lymphocyte. So what is the role here? As I told you, we are it is not minimally invasive, no need for incision or excision, no skin necrosis, and improve skin condition, significantly reduce the whole limb, minimize psychological disturbance, and increase the acceptance and satisfaction with the patient. This is what we found. Also, we use it if the patient fail conservative. After we do him all the other measures, then we do a laser and follow by complete decongestant therapy and then compression. If the patient fail, we go back to lymphodepletion and follow the conservative. So each patient, we decide treatment different from the other. And this is, I show you some of our cases. This patient, when she came, she has, she is have 6 years lymphedema. She received post mastectomy with axillary lymph node dissection and radiotherapy. We use for her lymphodepletion, low laser therapy, low laser therapy and complete decongestant therapy, and then followed by compression therapy. And you can see before when she came and after, you can see the reduction after treatment. There is reduction of the limb size and improvement of the softness of the skin, and the skin, the volume reduced. And this one, another patient, she has post mastectomy and with radiotherapy and lymph node dissection. And we use the same lymphodepletion, low laser therapy, and complete decongestant therapy, and followed by conservative measures. Follow up 11 years, and you can see there was big difference between the normal and abnormal at the beginning, and this is the difference improved after we use this type of combination therapy. Another patient, the same. She has post-mastectomy lymphedema, and this is the difference before treatment between normal and abnormal. And there is reduction of the swelling after the therapy, and she has follow-up 12 years treatment, follow-up. And this patient, the same, she has the same type of treatment. There is improvement of the limb, the size, and improvement of and there is softening of the skin. You can see there is difference between each patient. It depends on the risk factor, obesity, and the patient compliance, and this all affect the outcome of our treatment. This patient has lower lymphedema with chronic. He used something to treat his lymphedema, corrosive or something. I don't know. He used chemical. It makes the skin very bad. And I use for him low laser therapy, and there is improvement. Even the skin texture, there is improvement in the size and the skin texture. And patient follow after that the conservative therapy. This patient came with chronic inflammation. We treat her cellulitis, and after that we use this type of treatment, low laser therapy and conservative, and there is improvement, and it was follow up more than 4 years. The same other patient, lower limb lymphedema, long standing, and the patient, she received the same type of treatment. You see the difference before treatment, and there is improvement and reduction of the limb and patient follow-up is also more than 10 years. And this patient, the same problem. Most of our patient is primary lymphedema. And you can see the same improvement. This patient, she came with morbid obesity to 190 kilo weight, and she cannot move from chair. And I use for her the same technique, but then I advise her to reduce weight. She cannot move. She go for bariatric surgery. She lost 100 kilo, and I follow her. And this is before treatment. You can see after low level therapy there is improvement, but still very bad because the patient is not moving and morbid obesity. And this after she reduced the weight, you can see how much improvement. She lost 100 kilo, and now she is only using conservative therapy. There is much improvement of this case. This patient, he came from the beginning. He's soldier. He stand all the time, so he has this type of deformity, long-standing lymphedema. Then I start putting him under the same regimen, low laser therapy and decongestant therapy. He received more than 12 sessions. Each session 40 minutes, low laser therapy, and followed by half an hour decongestant therapy and compression. And the patient, after that, because he has this deformity, he cannot wear elastic stocking, then I take him for liposuction. The only case after low laser therapy, I take him low level laser, I take him for liposuction. It was astonishing because all my cases for lymphedema, when I do them lympho-liposuction, it is fibrosis and no fat. But when I do liposuction of this patient, after this, he was in the hospital for 1 month. After our treatment for him, we found that it's fat, like when we are doing liposuction for a normal area in the subcutaneous fat. So the liposuction, we remove the fat, and there is improvement of the size, and we follow him. Unfortunately, he disappeared, this patient. He did not come back. He came from far area, and I don't know what happened to him after that. So in our study, the patient, the third regimen, we use low laser therapy. We did 30 cases over 10 years. All participants received cycle of low laser therapy to affected limb, at least 12 sessions over 4 weeks. The session 40 minutes, 3 times a week, followed by a session of 30-minute complete decongestant therapy. And the 29 patients, they receive only this treatment, but the only patient I use for him liposuction is the last one I show you. And I believe that especially in our type of cases, the combination technique, and each patient we decide for him a special way of treatment, and it affects the patient and improve the outcome. In conclusion, as you see, our majority of the cases they improve with conservative therapy and complete decongestant therapy. Some of the patients, they need to improve the effect of this by lymph-liposuction. Other, we need to give them low laser therapy. And lymph-liposuction, usually it is closed technique of excision, no skin necrosis, simple and minimize the invasive technique, minimally invasive technique, improve skin condition, does not jeopardize the blood vessels or lymphatic, improve this as Hakan Brosson. I invite him, and we was discussing this the same result, improving improving. We found it improve the lymph flow and improve microcirculation, improvement of lymphatic physiology of the limb indicated by our patient and by study of isotope scan. It significantly reduced lymph and improve the contouring, and we can repeat it if the patient need. All our technique are measured disturbed if the patient has infection, or if the patient not follow our conservative measures and not the poor compliance. As I told you, the low laser is similar to the other. We found it the same. It's improved it caused softening and improved the flow and it reduced the limb size, and even it improved the texture of the skin in chronic cases. And this is thank you very much. This is our hospital, and if you need any questions, thank you.
Thank you, Professor. Really appreciate it for your talk and for the topics that you have pointed out. I would like to ask the attendants if they have any questions. They can write it down in the Q&A, and or the panelist, Dr. Faris and Dr. Yasser, if you have any questions.
Doctora. Excellent presentation.
Thank you.
Excellent outcome, صراحة. What is your pre-operative workout? Only you rely on lymphoscintigraphy, or you do MRI or CT scan to see the content of the soft tissue before going for liposuction?
Well, as you see, the cases are different. It depends on the cases, but mainly when we start on when I was the resident, I was in 1985. When I start in the department, there was many cases. It is not common in our country at the beginning, but it is referral. Many of them coming from Africa, from Yemen. Then we start doing conservative, and this patient very difficult to follow the compliance. Then we start the idea of liposuction. As I told you, 1987. We do the normal preoperative, but the most important is our finding, clinical finding, and the lymphoscintigraphy. We start doing this. As I told you, we do half limb, not the whole limb, under tourniquet and antibiotic, and then we follow the patient after that with conservative therapy. I introduced this late, the decongestive therapy, and it improved the outcome. It was not a center, it was personal work. When I start with the patient, even I cannot find elastic stocking for the patient. It's very hard for me to follow these type of cases, and the patients are very poor, and we treat them for free, and we bring the stocking ourselves. And I improved the outcome, especially when the patient came, when we have physiotherapy, they start, we collaborate with the physiotherapy, and then we start the decongestive, and I found there is much improvement. We have many cases, and even the decongestive therapy, the patient coming from far area in the kingdom. So that Dr. Safa, she helped me in the physiotherapy, physical medicine, to modify the regimen. I will send you the paper. Even they can do themselves at home, and she teach him how to do it. So the only investigation we do after clinical examination and history, we do lymphoscintigraphy. We don't do any other investigation.
The other question is the approach of lymphedema is the same approach as lipedema in your hands?
No. When I diagnose lipedema, especially, you find the foot is free, and the patient usually obese, or they have congenital deformity. I ask the patient to reduce weight, and then to do liposuction. If I will do for them for contouring, but not for lymphedema, because that is completely different entity. And I believe there is no place for them for this management if they follow, unless this patient sometimes when they go more with obesity, and sometimes they follow and ask the patient to reduce weight. This is the most important management.
Thank you, Dr. Faris. Professor, I do have a question. Me and Dr. Faris, we attended the last WSRM meeting in Mexico, and there was a big debate on liposuction. And some authors, they were in favor, and the others, they were against that evidence or that utility, saying that there is a risk of lymphatic injury, as what Professor JP have mentioned for Dr. Yasser's question. So have you did any MR lymphangiography after the liposuction to see the lymphatic status?
No, but I follow Professor Hakan Brosson. I follow him. He was doing a lot. He was having a big project, and he do a lot of study. And he said there is no damage of lymphatic. I invite him to my conference. I was the president of there, and he came and he told me it seems that I start really with very difficult cases, a chronic lower limb and long standing. And when I do liposuction, I never find fat. It's always we are breaking the fibrosis, and we are making what the idea is different from Professor Hakan. He is doing for lymphedema of post-mastectomy. That is different. Our cases, when we start, we do for dry, old, very chronic lymphedema. So we do communication between abnormal and normal. And the idea of mine is, you see that child, when I see the patient and we investigate her, and then we said maybe we will find something in this big mass. There's nothing. It was fibrosis. I do breaking of the fibrosis, and I do for her a channeling between normal and abnormal. And I found, even myself, I found there is much improvement after 1 year. And then I do for her the second stage. We take biopsy from that area. We did not do any resection. And then we found now the child, I follow her until now. She's now 14 years. Her father is physiotherapist. And she came from Mecca. The child is improving, and even the lymphedema was improving. Her father follow her up, and he do for her the decongestive therapy himself. So I didn't do, because I follow Dr. Prof. Hakan technique, and I think we start lower and we start upper.
Perfect. And one last question is that do you use any energy devices like Vaser or
No.
Right.
I'm worried from necrosis. I worried from all this type, because we follow minimally invasive, and I do all the work with blunt needle, and with even the liposuction. It doesn't bring only fluid and fibrous tissue. I think our technique for the lower is different from the upper, because upper you are removing fat, we start that one late after 2000, but in the lower only fibrosis. You are breaking the fibrosis, and you do communication between abnormal and normal side. This is what we found in our study. But in the upper limb is different. You are removing the bulk tissue. So we are treating very late stages and no fat. It's only fibrosis. And we believe that this breaking of the bulk of the tissue, making channel between normal and abnormal, it has an idea before they are doing like thread or something. We believe in this point, it improved the outcome, and only lymphoscintigraphy we are following, not other technique.
Perfect.
So this topic is evolving. So there is a lot of interesting studies going on. If you do a professorial MRI before patients, before you go to surgery, you will find there is a huge fibrosis, especially in late stages of lymphedema. Also, Professor JP Hong, I think they are working on a study of they do the MRI preoperatively. They find a lot of fibrosis, especially in late stages. After that, they do LVA. They notice that after the LVA, within like 1 year or so, they see some improvement on the fibrosis. The fibrosis is less after the LVA. I don't know whether they publish it yet or still ongoing. So I think this is a very interesting topic. Keep evolving.
Wallahi, Dr. Faris, when I start, I was alone. And it was very hard to treat this type of patient. And the patient poor, never follow the compliance. I didn't do MRI at that time. It was not easy to do MRI. It was 1987. Not easy to do these cases. Most of lower limb from Yemen and from Africa, to do scintigraphy, it is very hard. So when I do this to prove that patient have lymphedema and then follow with lymphoscintigraphy, and this is what our finding. But I think we leave this for you, for the young generation. I'm very happy when they talk to me about lymphedema, because I was going to all conference all over in our area to convince a general surgeon about lymphedema management. Because when the patient come to me, I said, why you come very late? They said, everybody said, no management for these cases. There is no management. There is management, but there is no cure. So this message was for all. Then I was educating the doctors and the staff and the patient. And I'm happy. I'm happy because the people thinking, and he is very, very more these people in Korea, and I was in Barcelona, and I see they are using sophisticated method. It is not for our type of patient now, at least, but I think later you will do this. The young generation, they follow, but this is I give you how we treat these type of cases in very, very difficult situation. Now I cannot see this patient after, now there is
excellent result, Professor.
جزاك الله خير.
الله يعطيك ألف عافية. والله very insightful talk, and it reflects what's going on. What kind of patients, totally different patients, advanced cases and complicated, and compliance level and education level is totally different.
Yeah.
So yeah,
I think when you follow this regimen for the difficult cases, I think it helps you, because I manage these cases over the last 37 years. Until now, I see some of them coming to me. But the new cases, when you see patient with early, I think that is you can go for the other. But this type of patient, it's hopeless. Sometimes you feel you don't know what to do with this type of patient. Then what if there is any hope? When I found there is low laser therapy effect, I immediately go to it, and I found really it's affect the patient. Until now, I do some cases, but not much like before. Really, it is really difficult and need. It is negligent from the healthcare, negligence from the patient.
Yes.
Education. Wallahi, we need education to the doctors, to young generation. If you told the plastic surgeon, even when I was introducing my lecture in other conference all over the area, Middle East, they never accept my lecture. They don't accept. The last presentation of this lecture, it was in Barcelona, 2014. Nobody accepting this type of presentation. They feel it's awful, nobody like it. So I think it's nice to find a new generation thinking of this type of patient. We have patients now, especially the secondary lymphedema, and you need to do nothing except education. It's simple, it's education.
Yes, totally.
I think this is your turn to work, and I'm happy to help.
I really appreciate everyone's time, and really appreciate you, Professor Musharraf, and Professor JP. Musharraf, I'm sorry, and Professor JP. I think he has some commitment, but I really appreciate, and Dr. Yasser, Dr. Faris, also. We have many attendants from the Saudi Lymphedema Framework, SALF, also the المستشفى السعودي الألماني, Mr. Jian as well. Really thank you all, and really appreciate it for this time and the insightful talks presented. And زي ما تفضلتي Professor Musharraf, we need to work to educate our colleagues.
General surgeon.
Yes, we need to spread the knowledge
Yes.
that there is solution. Nowadays, people even are talking about preventive surgery for those kind of patients before lymphedema started. During the surgical resection, we need also to start collaborating with our lymphedema therapist to develop some sort of multidisciplinary service in our region. لأنه الdisease burden is huge. We have many primaries because of our congenital anomalies that's common in our region as well. زي ما
Yes.
تفضلتي
I have
Professor.
family with 4 person. يعني
Yes.
the brother came to me and he told me I am and my sisters. And when I explained the treatment, he said, no, I don't want this type of treatment. I want immediate treatment. I said, no. And he disappeared. He and
Wow.
3 sisters. Wallahi, I was shocked from him. And he is a doctor.
Wow. It needs hard work. So I'm really thankful for everyone, and I wish our attendants had a very insightful view on the problem and the current solutions and what's been practiced as well. So thank you all, and
Thank
really
you very
appreciate
much.
it. Thanks a
Thank
lot.
you very much.
Thanks.